the first big domain that is in many ways a controversial topic that's different for every community is flexing and resource sharing. So as pediatric hospitals, some of us are freestanding, some of us are tied to adult hospitals, and what each institution is doing in terms of sharing equipment or PPE equipment or bed sharing or surgeons covering adult units or kids being concentrated in just the pediatric hospitals to make room for the adult hospitals, or ICU docs that are consulting on the adult units. These kinds of things, I'm interested to hear what each facility is doing. Steve, can we start with you?
Sure. Well, the density of medical centers and hospitals in the New York tri-state area is enormous. And, you know, we're so deep into it now that New Yorkers love competition, but all boundaries have been put aside. Everyone is trying to help each other because the surge is skyrocketing at an exponential clip. So the governor, the mayor, they may fight every day, but they're looking out at the bigger picture, as is the health commissioner. And yeah, we're all helping each other. At New York Presbyterian, we have 12 hospitals, and every decree, every rule, every policy is with all 12 in mind. And so one of the things I'm sure will come up is, do children's hospitals take in adults? And what we've decided at New York Presbyterian, which is a good thing, is that all pediatrics is closing everywhere except Morgan Stanley. And so we're funneling in all of the children who are in our system but at other places to make room for their adult surge, even though that's filling us up. At the same time, the adult facility is borrowing our pediatric providers. So, you know, we're kind of working against each other, but that's settling out. But that's how we're doing it. We're going to fill the children's hospital with children and empty beds in the neighboring facilities that are part of our system. So yeah, that's one way that we're going.
Yeah, and I love that approach. We've begun to do some of that here as well, of concentrating the kids and the non-COVID kids that need medical care, whether it's babies or cancer or trauma, in one building.
Yep. And
hopefully freeing up everybody else. So it's a good approach. I like it. Adam, you guys have any comments on the resource flexing issue?
I mean, not too much. As being freestanding, like some of your hospitals, and being pretty far away, we haven't, just looking at the questions that you have sent over, we haven't had any discussions about loaning equipment. The PPE issue, most of it has gone to the adult hospitals. We did just have a donation of 18,000 masks, but my understanding is that covers us for about a week in normal operations. So there has been some sharing of that type of resource to all of the hospitals in the area. We have been talking about what Dr. Stiliano said, shifting patients from the adult environment, especially Harborview, over to children's, but also maybe increasing our age limits so that we can cover some more of the older, up to the 20s type patients who may develop COVID in our ICUs. And then the last thing that I would comment on is there has been some escalation of ideas to try to share resources across all the different hospitals, which comes down to credentialing. We have a lot of issues with unions, especially nursing unions in the state, and trying to create some expedition of credentialing between nurses and physicians so that they can cross-cover different institutions across the city. But that hasn't come to fruition. It's just in the discussion phases right now.
Those are very important points, Adam. And we've done the same with trauma, where we bounced the age up congenital heart surgery in adults. We're going to do those here. And obstetrical ICU needs for the moms, we're going to keep them here too. So we're trying to do everything that we can because our adult hospital is just bursting in ventilated patients. One of the things that I sent in by attachment is something on scope of practice and liability, because we can move practitioners across 12 different hospitals now. And I think those are very, very important points to sort out as fast as you guys can.
Do you traditionally have an L&D unit attached to your children's hospital, or is that a new?
Yeah, it's a women and children's hospital.
Okay.
So they're here.
Okay. Samir, how about Michigan? Any sharing issues?
So at a statewide level, all of the critical care, intensivists, adults, pediatric, everyone is now part of a network called MCCCN. And that's the website name, mcccn.org, where all of our resources are now pooled there. We're kind of somewhat aware of like what is happening at a statewide level as to which hospital beds are being used up and where people need to get diverted. It's not completely coordinated, but at least the educational information and resources are being shared. From an adult pediatric unit, we stopped doing elective surgeries for a couple of weeks now, and we've transitioned a lot of our patients outpatient, and that's for all of the places that we cover. So as many of you know, our model involves covering our outlying facilities as pediatric surgeons, and we've stopped doing surgeries at every one of those institutions. That way we can preserve PPE, we can preserve, intubations, ventilators, hospital beds, so on and so forth. Our regional ICU is actually located at Mott Hospital, and that's been filled. And so we've definitely hit capacity there, and now we're using up regular ICU beds. So it's pretty, we're definitely in the surge right now. We've been preparing for it in terms of our practitioners using Lombardi model by decreasing the number of people in the hospital. Because we've reduced our elective surgeries, there's less of us that need to be there. And so there's hopefully less exposure for all of us. And then we've changed our system so that there's one person on call as the surgeon, one person on for the ICU, so that on any given day, there's less people here in the hospital. We're also giving up our names for deployment to the adult side as needed for both surgery as well as ICU care. And so if we're needed on the adult side, we would then help provide care for the adults as well. I don't know, what else did you want to know on there?
That's nice. So you've created a peds surgery, peds intensivist pool of providers that are willing to cover. Does your ICU, because you're the critical care guru, does your ICU have any tele ICU connections to the surrounding hospitals?
No, but there's a weekly Zoom phone call like this in terms of discussion of, so like we had one earlier this week around, management strategies and what's being done and so forth. And so that everyone has the same expectations in terms of who would be provided ECMO, ventilator management strategies, so forth. And so it's with all the critical care intensivists in Michigan, not just at Mott or not just at U of M, but like all of Michigan. And so it was just, the basics were, discussed in terms of this is how we would manage. These are criteria that we could potentially use so that we stay consistent within the whole state.
Got it.
And we've been in shutdown for a little while in terms of shelter in place and so forth.
Great. Mike, do you want to comment?
Sure. So Rainbow is part of a large healthcare system. So we've got 15 hospitals, 30,000 employees, 3,000 physicians. So they've really tried to leverage that network. And what they've done is for all the physicians, we had to fill out a basic survey of what our skills were, what our board exams were, what our skills are as far as intubation, central lines, et cetera, and then create a large database of who is competent in critical care and ICU skills. And that's how they're starting to triage and be able to then resource out. The healthcare system, what they've actually tried to do is designate 2 of the community hospitals, East and West, as those are going to be the COVID hospitals, trying to preserve some capacity at the main academic medical center for, the emergent AAAs, the emergent cardiac cases, the transplants, etc. With the sickest of the sick COVID, they actually have deployable shock teams that will go out to these community hospitals, help stabilize them, help put them on ECMO if need be, and then bring them into the main medical center. So as far as the pediatric capabilities, and kind of somewhat positioned Samir as peds, surgical critical care, we're just in this pool of folks that are around and available to back up the adults.
Okay, sounds good. And then for the next topic, let me, in the interest of time, hopefully this can be really relatively brief, because I think my guess is all of us are doing roughly the same kind of thing. And this is for the educational programs. So this has to do with questions of restricting the residents, protecting them from COVID positive patients. How many residents are going into the OR? Did you change their teams? Conferences going to teleconferences and virtual, these kinds of issues. How's it impacted the fellow and the resident training? And like I said, my guess is we've all kind of done basically the same thing. I'll start with Adam. What are you guys doing?
We've gone, we shut down everything a couple of weeks ago. So we went to a complete WebEx educational program a couple of weeks ago throughout the entire university system. Even our group of attendings, we have a faculty meeting weekly, and we've done that by WebEx as well.
Okay.
The university system has created a pool of residents. Those who wish to can volunteer to take shifts in the medical ICU, either at the university or at Harborview. They've also created a tiered system across the whole graduate medical education system, where the surgical residents, they're going to have 3 of them per week, who may, if needed, they haven't been needed yet, would have mandatory rotations a week long in the medical ICU. So that's essentially what we've done across the whole system. In terms of seeing patients, we're trying to shelter both residents and fellows from seeing the COVID patients as much as possible. The hospital itself, across surgery as well as medicine, has taken to almost a doorway telemedicine, where we're having most of our conversations by phone with patients at the door. And then just going in for the critical things like a physical examination, or if there's any change or a wound check or something like that.
Okay. Yeah, I think we're pretty aligned with all of that. Steve, how about you guys?
Very similar. We're 100% virtual and web-based. In terms of our support staff, our office staff, we have about 20% come in every day. And the resident staff, we have about 50% come in every day. There's more of a pull now for our faculty to help in the adult hospital, and we've raised our hands and are on the pool now. The interesting point is the new ICU model. I sent that along as an attachment, but it's a kind of a new paradigm of taking, having the real great critical care people supervising these pyramidal teams that can, handle 100 and some odd patients who are ventilated. And but that's, I guess, for a different topic. But we're completely web-based, and we're not. It's interesting. They're trying to protect me because I'm an old man. So I mean, you feel like you're in the battle, in the trenches, and then somebody says to you, "Why don't you stay out? You're a little old." So take it easy on the old guys, okay?
And for what it's worth, your pyramid, I took a look at it. It looks really tremendous, actually, and it will also, from what Dave was telling me, go up on the APSA website.
That's great.
And so it looks nice. I think it's useful for a lot of people. Mike, what education stuff? Same kind of paradigm?
Yeah, very similar. The medical students have been gone. The medical students actually set up a pool where they're helping. They set up a network to help the physicians run errands and do childcare and all these other out of hospital stuff, which is great. You can request a med student to come like pick up your dry cleaning and walk your dog.
That's amazing.
Which is amazing. And then for the residents, for the education, it's all gone web-based in the last 2 weeks. We've really limited the residents. The residents aren't doing things like pre-rounding or seeing consults. So the residents, if they get a consult, they do all the things to the EMR to figure it out. They'll give us a call, and we'll decide together who actually needs to go in the room and examine the patient. And we've just really trimmed everything back, exactly what the other guys were saying.
Okay. Samira, how about you guys?
We decreased how many pediatric surgery fellows are rounding at a given time. Like we just alternate them like every 5 days. And then the number of general surgery residents have definitely been pulled back in terms of the number of people that we actually need because there's no elective cases that have been happening. The ICU, though, our staffing has pretty much remained the same just because congenital anomalies, traumas, cancers, like all of these just are occurring at the same frequencies. So we're not really seeing a huge dip in ICU census per se. And in fact, it may be growing.
Hey, what are you doing with your ICU, your critical care fellows? Are they cross-covering with the adult units, especially out of need? No?
Not yet. I mean, we've been pretty busy as it is.
Got it. So the next kind of domain of questions that we had listed all revolve around actual clinical changes. And I think when we were talking about this is where it conceptually gets into the pediatric specific kinds of things. And so the examples from places I've heard is stuff like, well, we should encourage antibiotics for appendicitis rather than doing them laparoscopically. That's a valid thing. So we should, not do it as much, or convert to open pylorics because laparoscopic is a potential risk. So and hopefully you guys can see the questions of the clinically related stuff. So I'll go around and let people comment. I presume everybody has canceled elective cases, and I'm going to presume everybody is mainly doing teleclinics for your outpatients. But if you're not, please, holler up. So let's start again with Steve. What are you guys doing that's different?
Well, limiting encounters is very, very important. So, the rounds look totally different in that one person goes into every room rather than, 11 like it used to be. The students have all been sent home, of course. In terms of specific things, across the board, when the N95 respirator masks are so precious, what we're doing now is covering them with disposable masks and throwing the disposable one away to try to preserve the integrity of it. And then our engineers are coming up with a way for those to be sterilized. So, I couldn't emphasize more how much the PPE issue was really had its hands around our throats. And just now there's been some relief with some plane supplies from China and from other places. But you're going to have to get really creative. And that segues into the aerosol of the laparoscopy. It's presumed that it's in there, and so we're using gas retrievers on every case. But you know, something's got to be escaping, and that leads to the controversy of appendicitis. You know, a couple we gave them antibiotics and sent them home the next day to limit the encounters. Others say, well, we normally operate on them and send them home from the recovery room. But I think the intubation and the aerosolization, if that's a word, just sound to me like they're more significant than having a kid in bed for a day. And so while we were biased against non-op in the acute setting, we're using it now. We're using it now. We think it limits encounters, and others can, you know, can counter that. I did a pyloric today. We did it with the gas exchange system. We rigged it up. We do test everyone that's going to the OR, unless it's life-threatening, and know their status in advance. And so our group just met today by web to say, if they're COVID positive, what should we do for appendicitis or for pyloromyotomy? And we're sorting that out. But we do want to know. And testing has gone through a change every day at our institution. Who's being tested, how they're being tested. I think it's just better for people to know, because it's such an invisible monster that you don't, you know, nobody looks any different. Nobody's any sicker or not as sick. But we're operating on them and maybe exposing ourselves. So I'm sorry I don't have definitive answers, but we're struggling with these things every day and trying to do the best we can. And I think just limiting encounters is the only thing we can do that's we know works.
Yeah. No, your answer is tremendous. How fast is your testing turnaround?
We're now down to 8 hours.
So you can theoretically send off the test on almost anything.
Almost anything.
And
you know, today they transferred up a 1-month-old with a truly incarcerated hernia, and you know, we treated them as if they were positive, because that went right to the OR. But almost everything else, we got 8 hours, and we just feel like we should know.
And when you're positive, when you say a COVID positive in the OR, you are N95 goggles, or are you doing PAPRs? What's your OR positive protocol?
We're using face shields. We're using the N95s, and anesthesia is intubating the patient in a negative room, which is not in the OR. It's right outside the OR. So it's like the old days of an anteroom.
Yeah.
If they know they're positive, they're intubating them in the negative room. If they're not sure, we haven't had consistency yet.
Yeah. And by the way, as a tip, the sterilization, Nebraska's got a really slick system for UV towers sterilizing the N95 mask.
Awesome.
Yeah, sick your engineers on it.
Yep.
Hey Adam, I know you guys have done a ton of changes.
Yeah, I think I sent the protocol that our anesthesiologist came up with to Lauren to post in the QSC toolkit. But we, just like Dr. Stylianos is saying, we reinstituted having an induction room. So every patient going to the OR gets tested for COVID. So we stopped doing all elective cases, but you know, for the last year, our hospital has canceled cases because of our aspergillus thing that you've probably read about. So we're really behind in terms of cases, but we're very, very familiar now with ranking our cases by red, yellow, and green. So we're really only doing red level cases and yellows, so things that have to get done. So anything that is what we, you know, in our elective world right now, which is essentially a yellow case that needs to get done within a week or two. So those are tumors and, you know, central lines for chemo, biopsies, and things like that. Or bleeding ulcerative colitis patients, or, you know, anything like that. They're getting tested 48 hours before coming to the OR, and they have to be negative before moving forward. All inductions are happening in an induction room. There is just a single anesthesiologist in the induction room in a capper-papper type of environment. For any patient that's positive, we're waiting 30 minutes because that's what they have decided is the amount of time for any particles to settle before transitioning them to the operating room. and then doing the case and then reversing that where they're extubating. So all aerosolized cases are being performed in that kind of maximal safety environment. Patients, like Dr. Stiliano said, we're treating appendicitis. We had a bias against antibiotics only, but we are treating some patients in that way. If they're COVID positive, anyone who is, they all get tested for COVID. If they're negative, then it's surgeon preference. And many of us, because they can get out of the hospital same day, we're just operating and sending them home rather than having the 20–30% recurrence and risking a longer hospitalization. And we're doing the same for other things that are in that appendicitis type of space, trying to limit any contact, minimize contact, and minimize OR as much as possible.
Okay. No, that's an amazing change of all sorts of stuff. And of course, neither of you guys are doing clinics, I'm guessing.
We looked at all of our clinics through the end of May and canceled basically all of them. Each of us had maybe 1 or 2 patients that had to be seen. The rest are either telehealth, phone call visits, or just delayed for another time.
Yeah. And same for you, Dr. Stilianos, no clinics, right?
Correct. No on-site.
Yeah. Mike, what are you guys doing?
Very similar. So basically, all elective cases canceled. The Ohio governor had mandated that across the state. So in developing to a tiered system, for cases that do have to go are considered the essential cases. It's very similar to what Adam was just describing, where we're doing intubation in a separate room. There's minimal personnel at 1 or 2 anesthesiologists, ideally negative pressure room. The transport to the patient, we're basically completely bypassing the pre-op holding area now. They just come straight back into the ORs. And exactly as Steve was saying, kind of minimizing any touch points within the hospital. Intubation is done, again, with really no one else in the room. Waking up also in a negative pressure room. As soon as they wake up and get extubated, they get a face mask on, whether they're COVID positive or not. We're just assuming that most people are. Our turnaround time for tests is not down to 8 hours. We're still sitting at 12 hours. And what we've come across now is an acute shortage of the nasal swabs, which I think is hitting other areas too. But they're really starting to limit who we can actually test. So we have not gone to testing everyone coming to the OR, just because we're just limited in capability, the capacity.
It's changing so fast. The announcement came out today that we will not be testing children for the routine respiratory viral panel.
Same thing for us.
Yeah, and keeping the swabs for the COVID. It's such a moving target every day. Official announcements come out and they're very different than the day before, but they're doing the best that they can. Try to keep us safe.
And for us, the testing restrictions is the swab availability, and we've got them, but it's certainly one of those supply things that we're worried about. And it certainly limits the amount of tests that we can do. Samir, how about you guys, especially in the ICU? Have what's changed that's clinically different?
I think we've definitely had testing limitations. In terms of the ICU, I think we don't have any major changes to report. We've done some of the same stuff that's been described in terms of the operating room, in terms of waiting after intubation, not having people in there, and then in terms of PPE, similar type of things, treating everybody as if they had it.
Okay.
We'd be definitely interested in like filtration system around like laparoscopy because of the SAGE's recommendations around potential for viral particle spread with laparoscopy and during like CO2 release.
I sent a file over earlier, so that might be around.
Yeah. And by the way, Samir, Dr. Stylianos also has these great ECMO protocols, and we'll share, and those will ultimately get up on the web as well. I don't know, has ECMO for you guys changed, or is it the same?
So we have a universal, like, centralized system of who ends up getting ECMO, but we've basically reserved it for in terms of COVID, for younger patients, minimal comorbidities, single system, single organ dysfunction. The rates of success with ECMO and COVID, at least so far, haven't been very high. It's like 10–15%. And so we've been relatively conservative about use of ECMO. But at the same time, many of them have responded to just standard measures in terms of ventilator management.
Okay. Got it. Nice info. So just to last domain to wrap this up is taking care of yourselves and your team and wellness. And I'm interested to have everybody comment on two things. Do you guys have members of your team, or how many members of your team have been quarantined and positive, and is it do you have other surgeons that are now trapped at home? And the second part of that question is how are you all dealing with family and your own mortality and your own risks and worries about taking stuff home?
I can tell you from the perspective of a first-time grandfather. I have a 1-year-old grandson, and at times like this, there's nothing better than a dose of him. And I haven't seen him in 3 weeks, even though he's right nearby, because how could I? I haven't seen my wife has stayed with me out of 40 years and even through COVID. But we talked about separating completely as a family and isolating me because I'm in this mess every day. Yeah, it's painful, and I think we're all going to have some reactions later on. When we start to think about what we just went through. But right now, it's combat time. It really is. But I really do miss the comfort that comes from our families. That's something we've always had to count on. And right now, every time we think about hugging them, we might hurt them, and so you don't.
Yeah,
it's tough.
Yeah, it's a problem. Hey, Adam, how about you?
So many of my partners and I think I mentioned this on the QSD call the other day. We're being perhaps overly careful. I don't think so, but I have non-OR scrubs, just general staff scrubs. I change into a clean, untouched pair. Don't touch anything on my way out of the hospital. I have a pair of shoes that I wear from my office that doesn't go anywhere near patient areas to the car, and then from the car to the office. And then I change into a different pair of shoes to see patients in the hospital. I don't bring anything from the hospital into the house. I basically, even though they're clean scrubs, I have a jacket that I leave in the car. I don't even bring it into the hospital. And that's what I leave that in the car when I get out of the car to go into the house. Basically take off my clothes and jump into the shower and put my clothes in a bag and leave my shoes, almost outside the door, so that I don't bring it home. I have a 76-year-old mother-in-law in the house, and if she gets it, that would be the end of more than just my marriage. So our group is being really, really careful. I think I mentioned also on the call, we've taken everyone 60 and over out of our clinical schedule. So they are not seeing patients. They're allowed to come into the OR for cases that they've had scheduled for a period of time that are more complicated, that we need them. But for most cases, for all call, for all surgeon of the week and surgeon of the day and surgeon of the night activities, no one over 60 is in our clinical rotation right now. They're staying home. We've also limited our exposure in terms of changed our entire deployment so that now we're only on 12-hour maximum shift. And after 12 hours, you go home and there's no more than 3 to 4 shifts per week, because our literature is that fatigue might play a significant role in your risk. So we're trying to make sure everybody is as well rested as possible.
It's a good point. Mike, how about you? Any partners positive or family changes?
Well, right now we're lucky that none of the partners have been positive or we've had to quarantine. We've had a couple of residents that have had to quarantine. As far as my wife and myself, and we got a couple of young kids, we're both on vacation this week. So we're trying to enjoy the family time and not be at the hospital. My wife is a PTR doc. So we're assuming when we both go back next week, she's going to at least be exposed, and if not, COVID. So thinking about how to isolate her in the house, and the same things that Adam was just going through. How do we keep it safe from our kids? How do we try not to expose it? My parents live nearby. They're in their 70s. They often help us with childcare, but we video chat with them a lot, and we basically said, we'll see you this summer. Not really don't want to expose them.
Interesting. Samir, how about you guys?
Yeah, I mean, much of the same stuff. And I mean, we all have concerns in terms of infecting our loved ones. But, I think, at least for me, I have kids that are between 5 and high school, and I think they should do okay, I hope. And we're trying our best to avoid bringing it home, same kind of stuff, extra pair of scrubs and showering, changing clothes, those kind of things. But I mean, at the end of the day, like, this is our job, is to go and take care of people. And like, this is what we're called to do. And like, and we're good at it. And so we got to go in and we got to work. And I think my kids and my family understand that, and they appreciate why I go into work, and they know to leave me alone at times and to cheer me up at times. But I've definitely not gone to isolating myself. I mean, I think that would be very difficult for me to do.
All right. Well, we're close to out of time, but I want to open it up for just kind of open forum, and especially if there's, I'm very interested in all of these domains and topics. Is there anything that we're missing? If we want to legitimately put together some guidelines for everybody, what else is not in these questions that we should be asking? And so, Dr. Powell, get in there too as well if you want.
So Dave, you had mentioned that you had over 100 submissions so far. How do you want to go through a process of filtering those out? Or is there any other topics that have been popping up in those that we need to address?
I think that's a really good question. We really don't want our resources to become so good that they're confusing, right? So we've asked the quality committee, the PDC, to kind of help us curate that. When there are duplicates, we try and pick the best and put the two together. Things that have been number one with a bullet, if you will, are novel approaches to PPEs, because I think people either run out or are worried about running out. It's a big deal nationally, maybe not for some of the really highly affected areas now, but nationally, about what to do with case scheduling. I think that's been an issue, and so we've tried to come out with a statement about that. I'm afraid ECMO is going to be a big deal, so Steve's suggestions about ECMO are really, really important. My question to you guys is, how long are you going to be able to hold out? I think, this is really, really tiring. This is really fatiguing. And Steve, you're farthest along of anybody. How long are you able to hang out despite your age?
Yeah, well, I think for us, we think about what's going on in the adult hospital right next door, and we're almost grateful that we could be in the children's hospital, even though, there's a lot of sickness here, a lot of moving parts, a lot of plans and protocols and policies, but what's going on in the adult hospital is just frightening, absolutely frightening. So listen, I don't know how long I could go, but you just kind of have to. One point I would try to make, though, is, pediatric surgery has always been criticized as not having enough randomized trials to make suggestions, but yet we live on the suggestions of our forefathers. This is exactly the same thing. There's not really a lot of data on COVID. We're doing the best we can, and I think the APSA membership should know that local rules are important. And if your healthcare system is doing the best it can and vetting these things through the smartest people it has, that's good. And it may not be what's done in, across the coast or over here or over there, but just as long as people are working together and doing the best that they can, I think there's got to be some comfort so we don't have tremendous regrets at the end.
Yeah, I'm going to echo that. I think there's, it's been my experience in talking to others, there is no one solution that fits every community. All of us have slightly different situations and practices and challenges, and it's all about local intelligence of getting it right.
And to Steve's point, even locally, what works today is not going to work tomorrow.
Yep.
Every single place is changing within its own self. It's just, I also want to thank you guys all for working as hard as you are. This is just, you're doing an incredible job above and beyond your normal scope of work. And thank you all for all you're doing. This is, this is really informative, I think, to me, and will be really informative to our members. We've talked about having a similar session or trying to reprise this session for the annual meeting, for the opening session of the virtual annual meeting. And we thought we'd be able to entitle it Lessons Learned from the COVID Crisis.
Yeah.
I'm a little bit skeptical that it's going to be lessons we're continuing to learn from the COVID crisis.
And
Dave, this might even be...
I was going to say just one thing, that besides the wine that I drink at night when I finally get home, this has been the most therapeutic hour that I've spent in 2 weeks. And I really thank all of you for just sharing, because it really, it helped. It helped a lot, and I really appreciate it. I really, really do.
Anytime.
And Dave, I was going to say, maybe even you should have something that's even made once a week, because this is changing so quickly. The same discussion a week from now might be very different.
Sure, I think that's, we actually have several different people we're going to change in and out of the panel. I don't want to burden all of you overly, but I think we will set this up as a regular thing as things change. This video and all the stuff that you guys have submitted will go up on the page tonight and go live first thing in the morning. So if you're interested in Steve's ECMO or ventilator management pyramid or Adam's call schedule and stuff like that, that all will be, some of it's already on there, but everything, we plan on updating that page probably every other day, depending on how things going.
That's tremendous. Yeah, how often should we do this? And maybe it's different groups, once every week or two? Okay.
I'm afraid you're all going to get a call like in the morning. We have to have one in the afternoon. just because of the way things are going. I appreciate you all being able to do this on short notice, but that is the way things are now, man. I'm sorry.
Thanks for setting it up, Dave.
No.
Yep.
Thank you.
Appreciate it.
All right.
All right,
guys.
Thank you very much.